Well, it's been a long day, I know, but I know a lot of information, and I have to say, oh yeah, sure. I have to say the questions that I have here, they are great questions, and I hope I can get to all of those, all of the questions, but if not, please do not hesitate to ask any of us at the end. And then another one, that's fantastic, wow. Okay, now because we...
here tonight.
Yes, and also, I may not do such a good job as Dr. Chauhan, but then I'll do my best. Okay, so I'm going to ask this question. This question will be for Dr. Esposito. If current PRT with Lutathera stabilize the tumors, will the new alpha PRT shrink the tumors?
So you saw that one of the clinical trials, one of the slides I showed you was a study. They had enrolled 32 patients, and one arm were patients that had progressed after Lutathera, PRT, lutetium-based PRT, and the other one where patient had stable disease, and so they had shown that some of the patients did improve, had tumor regression to some degree after the lutetium PRT treatment with the alpha. So again, these are clinical trials. This is very early data. The population was 32 patients. I can't remember how many were on the arm that had stable disease. But again, these are the data that we have so far. We'll need more of those data to know the answer. Yeah.
Dr. Chauhan?
I think there is a potential from early data, but we don't know yet. It's not, we don't have large data sets to say whether alpha would show more response rates or tumor shrinkage. Traditionally in drug development, what happens is smaller early phase study tends to show more shrinkage. Okay, so early phase studies for any drug, we have high response rates. Phase 2 will show a little bit more modest. Phase 3 would show more closer to the real world experience. So I think jury is still out, but it's a great new drug under investigation.
And on that sentence, if a patient had beta PRT with Lutathera and did well, and there is progression, can that patient receive alpha PRT?
Yes, I think there are two studies looking at, actually one study which is looking at alpha PRT at progression on beta or Lutathera based PRT. It's an industry study and it's using actinium based alpha PRT. So certainly look into it. One of my slides had a reference for that. And it's a large phase 3 study, so I'm sure there'll be plenty of opportunities to participate in that study.
Yeah, well, there's also the AlphaMedix PB212 that is finishing accrual for the PRRT naive patients that will now open the slots probably starting next month for patients that had previous exposure to PRRT. They showed signs of progression. That's not a treatment failure of PRRT. They showed signs of progression, and therefore they are moving into using PB212, another alpha emitter, PB212, instead of are considering using additional doses of lutetium, standard of care, lutetium-177. So there are active. So that's in 4 sites in the U.S., and we were waiting to fill the slots for the PRRT naive patients, and now they are moving into the people that have had previous PRRT. There has to be a 6-month gap between the completion of the lutetium-177 and the consideration of PB212.
Okay, that's great. So this will be a question for Dr. Maluccio, and the question is, can PRRT impact future surgical considerations?
No, but it sure doesn't make the surgery any easier. So I think that the couple things that I think actually you could put in perspective is radiation is something that's a lifetime. It's a cumulative exposure over time, and so the tissue just is a little bit more vulnerable to then additional insult. But that if you are choosing PRRT because you're trying to treat the totality of a multi-organ site involvement, there could be so many great reasons to choose PRRT without you knowing that something's going to happen such that then the patient ultimately needs an operation. I think when I made the comment about using PRRT earlier in the course of a disease, a treatment plan, without then understanding what surgery is likely going to be required, we would rather actually understand, well, it would be a lot easier and low risk to deal with that mid-gut neuroendocrine tumor, realizing that this is a stage 4 cancer, but that deal with the mid-gut primary, because then when that patient potentially gets an obstruction, you are definitely operating on more vulnerable tissue, and that just raises your complication rate.
Okay, that's great. Thank you so much, Dr. Maluccio. And this will be a question for Dr. Esposito. Could you please explain the difference between CT scans, single phase, biphase, triphase?
Yes, so the CT, of course, we can do a CT with no contrast, and then we would give contrast if it's indicated. So sometimes you do a CT with contrast, you just do with contrast, so the patient undergoes a CT after the IV contrast has been given. And then the other ways we can do is to do the CT in, so as we inject the contrast, it goes into, of course, into the vein, goes into the arteries, and then goes into the portal veins and all that. So single phase would be when we would give probably contrast. Dual phase would be when we can be either without contrast and then after every given contrast. And then third phase is without contrast, then given a contrast. So the arterial phase when contrast is in the arteries, and then a delayed phase or portal phase or venous phase. And so you can have single, dual, or three phase CTs. And for neuroendocrine tumors, again, the arterial phase is helpful, but for the evaluation of liver lesions, sometimes we want to have also a delayed phase.
Mm-hmm. Yeah, and if I could remark, since we don't have the interventional oncologist here, is that multi-phase cross-sectional imaging is really important for understanding response to liver-directed therapies, because the tumors will lose that enhancement on the arterial phase of the image, and so you will often just get, if it's a single phase, you just may not get all the information. So the triple phase scan is what we usually use in MR, but a triple phase CT scan is what we use after liver-directed therapy.
Okay, that's great. So this will be a question for Dr. Maluccio and for either Dr. Chauhan or Dr. Esposito. For a small bowel neuroendocrine tumor and peritoneal disease and liver metastasis, when would you recommend surgical debulking or PRT? Who wants to go first?
Let's fight it out.
Is this tumor board? Because this is seeming a lot like tumor board. I think that you won't necessarily recognize the degree of peritoneal involvement until after you're already in the abdomen. So if you have obvious, extensive peritoneal involvement, the surgical aggressive thing would suggest that that we are going to raise the likelihood of having complications of PRRT, of which we are actually not operating on the cancer, we're actually operating on the complication. Small volume, though, I probably don't feel as strongly about. I think that we would just end up doing a very low-risk operation, trying to eliminate the risk of obstruction at the primary site, not do some over the top because it's too early in the disease process, surgical cytoreduction, and save that. Now, I think that there is no right answer. I'll tell you that there is no right answer, and what didn't Blakely say, in the eye of the beholder? And so I think in the cases that we have taken, because PRRT was delivered elsewhere and then the patient either got a second opinion or had a complication, I'm not saying it's prohibitive to go back in there to the extent that I would say that no, we have to time these things more appropriately. No, it's not that bad. It's just one of those things where had we known what we know, we may have just at least put our head around it.
Yep.
I agree. Peritoneal disease is a very tough disease to treat regardless. And unfortunately, there are times where we see patients with massive amount of disease in peritoneum with omental caking, and it becomes very difficult to treat either systemically through PRRT or other agents, and even it's a challenge for surgeons as well. So it really needs to be tailored to the need. We know from Europe that the PRT success in the peritoneum is a little bit limited as compared to bone mets, liver, lymph nodes, where it really works really well. So there is definitely a role for surgery. Now, how do you time it? That's critical, and that is tailored for each patient, because you would not get multiple chances at it, right? So every time you have surgery, there are also more issues with fibrosis, scarring, and obstruction and things. So you want to get in when and get most of it out, if possible. Sometimes we do systemic therapy with the aims to shrink some of that disease burden so that we can help our surgical colleagues to kind of clean it up. Once the mesenteric disease is so extensive and it's causing bowel ischemia, obstruction, it gets very difficult. So I'm usually a proponent of early surgical site reduction, because I've seen it becomes very challenging to treat it with our medicines down the road. Unless, of course, my surgeon tells me, no, this is not a good surgical candidate. But yeah, this is the reason why it needs to be discussed with our surgeons in a multidisciplinary tumor board and have a clear-cut plan laid out. If we are doing therapy, at what point of time will we take the primary out, we'll take the metastatic disease out before it starts getting symptomatic.
And
Yes, Dr. Esposito. Yeah.
so if I can add, from the perspective of doing the PRT or planning for PRT, obviously the amount of activity, the radiation that we inject is definite finite amount of radiation. So the more disease there is, the more we have to divide the dose among all the different lesions. So it's more likely that a specific lesion will have less activity, right? So theoretically, if we can debulk as much as possible the disease before PRT, obviously that's the ideal situation. But that, again, is a surgical evaluation. Of course, the surgery, the risk of the operation versus the effectiveness and how much it can be achieved, or whether the patient is surgically a candidate or not. So that's on the perspective of PRT.
Yeah, and I think that when you go to that menu of options, I think that when you have extensive disease, that's not necessarily dire. It's just that that's what you got at that moment. And so you have to go to this menu, but you have to recognize that everything on the menu has proven benefit. So that's where a disease management team that really works well together kind of says, okay, this is our goal. Like, we don't want to burn any bridges here, but we need you to get up until this point. So maybe we won't go for 95%, but if we could hit the 70%, or if we could take out this aspect of it, so that then when you're bringing it back to the group, they don't say, you did what? Like, say what? And so everybody is kind of on the same page with, hey, this is our treatment goal. Did we meet that treatment goal? And then we're moving on, like, what else is on the menu? Because none of them are mutually exclusive. Other than, I don't think that we really understand in terms of myelosuppression using chemo back-to-back with PRT and double dipping on that type of toxicity. But the rest of them, liver-directed therapy, surgery, PRT, you can often use them sequentially,
Right. No, I mean, completely agree. And I just wanted to mention that the importance of having a multidisciplinary approach in the management of neuroendocrine tumors, and why the importance of also having a surgeon who has expertise in neuroendocrine tumors to weigh in some of these recommendations as well. So, question for Dr. Chauhan. When would you recommend active surveillance, and when would you recommend systemic therapies?
So me and Dr. Del Rivero, we are working on ASCO guidelines on neuroendocrine tumor. This is exactly one of the questions, when to do, so it's a good question. And even the NET specialists in the country are grappling with this. So what should be our, for guideline purposes, we can come up with some consensus, but honestly, the real answer lies in for individualized decision for that particular patient, okay? I discussed both the options, pros and cons with the patients. Usually the typical answer would be a very low bulk disease. And how do you decide low bulk disease? So some European data from Dr. Pavel in Germany were trying to come up with definitions. So under 10% liver involvement, etc. So that's a good definition, So low bulk disease, low volume disease, asymptomatic disease, and slow growing disease. Those are all the good buzzwords which can certainly justify observation. But if we are dealing with high bulk disease, we're dealing with symptomatic disease, and symptoms not just from carcinoid syndrome or functional syndrome, but just from tumor per se. One of the things that tumors does, it secretes certain chemicals like cytokines. It makes you feel sick, make you lose energy, make you lose weight. That's why cancer is a catabolic state, right? So it makes you, so if you're symptomatic from your cancer, that is not the time to do observation, right? And clearly, if the tumors are rapid growing, fast growing, you don't want to do it. So we have to kind of factor in what's OKI67, what's the bulk of disease, are you symptomatic or not, are you functional or not? If you have functional neuroendocrine tumor, you don't want to be on observation because uncontrolled serotonin, we kind of alluded to it, can cause a lot of other problems, right? So we have to really tailor these things. And so unfortunately, I cannot come with the one answer, but in the right patient, yes, there are times where I think it's completely fair to watch closely. When I do watch, I do try to get my first scan in 3 months to really understand what the biology of the cancer is. So I don't wait like a year or 6 months. And if that 3-month scan looks stable, then our bet was sort of right, that this is a slow-growing indolent cancer, and patient might want to continue that break. But most important piece of puzzle here is patient. The patient needs to make that decision. There are patients who wants to be proactive, and they would be very worried if they are not doing anything. So if I force my decision on them, hey, no, we are doing observation, that's not fair to patient. But at the same time, there are patients who don't want excessive treatment. They want to be proved that, is these tumors are growing or not? If they're not growing, they might remain dormant for 2 years. Who's to tell? The only way to know that is by watching and getting that first early scan, right? Either way, we are not curing the patient with the shots or starting any treatment. It's all about controlling the disease, prolonging the life with good quality of life. So those are the aspects you have to discuss with the patient and help the patient make the right decision for them.
Yeah, if I could add to that, because I think we live in two slightly different worlds from a systemic therapy versus surgical therapy. The number of times a patient will call for a second opinion because they think that their doctor's doing nothing. And I don't believe that the doctor really was just blowing it off and doing nothing. I think they were not communicating exactly what Aman just said. They weren't communicating the reassurance that watchful waiting in a low grade, even we do it in pancreatic neuroendocrine, sub-centimeter pancreatic neuroendocrine tumors all the time, but that it's instead they say, I feel like he's blowing it off, or I feel like they are telling me this is nothing. But I really don't think that that's the case. Either they just don't know quite enough about it to think that that small volume disease requires treatment, or they aren't communicating effectively the fact that watchful waiting to better understand the biology of the disease in this disease actually, has some value, but it's not going to have value if the patient is like, I feel like you're not treating me, like you're just blowing me off. Right.
So they need to have communication skills like me. Okay.
Dr. Esposito.
No, I wanted to reiterate in what Dr. Chauhan was saying, that sometimes we have the patient, everything has to be, the whole patient needs to be considered, symptoms and radiologically. Sometimes the tumor does not grow, it stays the same, but the symptoms are worse, right? The symptoms are worsening. So sometimes the imaging does not tell the whole story, right? So again, one has to look at everything together: the imaging, the clinic, the patient symptoms. So,
yeah, great point. And although I love the ability to do televisits and Zoom visit, but this is one aspect I feel sometimes miss out, because seeing a patient face to face and examining the patient, you get that extra piece of information which you cannot experience across the computer screen. So I completely agree with you, sir.
Yeah. Next question, Dr. Chauhan, because you have the retreat, and maybe Dr. Esposito. How many times can a patient have PRRT?
So it's a great question. So we talked earlier about the FDA-approved current regimen, 4 doses, that each dose is about 200 millicurie, so that kind of puts it at 800 millicuries. However, in Europe, prior to this NETR-1 study, they've been using it for years. And at progression, institutions there have a little bit easier access to radiopharmaceuticals, so they have tried it because there were not other options available. So we know from at least 13 published studies from various European countries that you can get additional PRRT. People have done 2 doses, some have done even more, 4 doses. Some have done 4 doses but with half the dose, so 100 millicuries, right? So all sort of cocktails have been tried. One thing, the common denominator is that yes, it can be done, and at least from the European data, we know that it can be done safely, and there is activity. For example, I'll quote one of the studies. So at progression, when they re-challenged with limited dose PRT again, at progression, patients were be able to reduce stability for good 22 months. That's one study. Other studies showed 13 to 14 months. So that's the range between 13 to 14 month median PFS to all the way 22 months. So it is still active at refractory setting, okay? One of the key things here would be though, if patient has primary refractory disease or secondary refractory disease. That means if somebody just got PRRT and progressed within 3 months or 4 months, I would be very skeptical of trying PRRT again in that patient because it didn't work the first go. So the patients we want to re-challenge is secondary refractory. That means they had a good remission at the first dose, so at least a year, I would say, right? Then it makes sense to try it again. But if it's happening before a year, then I'm really worried. There's a more aggressive biology, although they have the target, the somatostatin receptor, but it didn't respond as well. I'd rather try something else. And that's how the NET retreat study is designed. We are taking only patients who have at least responded to initial PRT for 1 year, and then we would entertain that.
Yeah, I don't know how we're doing in time, but yes, I completely agree with what obviously you were saying. There obviously is a patient is having side effects or progression during after 1 dose or 2 doses, we wouldn't do the full treatment. What in terms of looking at the future, one thing, at least in nuclear medicine world, what we're hoping is going to be a game changer is dosimetry. So we're looking in a way to really measure how much radiation we're given to a lesion, to 2 lesions, and so that is, so the end goal is going to be not just to give the 4 doses as approved for, but to do, if the patient can tolerate, as many doses as is needed to reach that amount of radiation that we think is going to be effective. There's a lot of work that we need to do, a lot of trials we need to do, a lot of refining of the measurements we have, but I think that would be probably one goal that we can reach in the future.
So this question could be for anyone, I think, but maybe Dr. Chauhan to start. If CAP-10 doesn't work to shrink the tumors, are there any other drugs that help shrink the tumors?
Oh my goodness, you've asked the whole neuroendocrine oncology. Well, it sort of really depends on what are we dealing with. Is this a grade 3 well-differentiated neuroendocrine tumor? Those are a little bit more tricky, or atypical lung carcinoid, or are we discussing low grade or grade 1, grade 2 well-differentiated pancreatic NET? So it's very difficult for me to answer that question without knowing the specifics. But if, sorry? Grade 3, well-differentiated or poorly differentiated? Well-differentiated, okay, thank you, that helps me a little bit. So grade 3 well-differentiated NETs are relatively new disease, as we discussed, and we don't really have a lot of good treatment options. However, we do have some options, and I tell my patients where we don't have options, it also brings opportunities because we can sometimes beg, borrow, steal the treatment options from other, like neuroendocrine carcinoma group or the low-grade group. So how do we figure out after CAP-10? It's mostly the biology of disease. So if the tumors are growing fast, if they are positive on PET scan, the FDG PET, Okay, so that's the type of PET scan that we often don't do in the low-grade NETs, but we do it very commonly in high-grade neuron. So if they are very hypermetabolic, that means very active cancers, I would prefer IV chemotherapy. And my common go-to chemotherapies are carboplatin etoposide, carboplatin irinotecan, docetaxel, and in lung space, we use this new drug called lurbinectedin. So we have quite a few IV options. But if grade 3 well-differentiated neuroendocrine tumor is not hypermetabolic like small cell or large cell or NECs, how would we know that? We do the FDG PET. And on the contrary, it's showing high somatostatin receptor. So this is a disease entity where I like to do both DOTA PET and FDG PET. And this is also sort of endorsed by ENETs as well. This is because we would otherwise do not understand the biology of the disease. So if there's a lot of somatostatin receptor positive disease, then we have a wonderful clinical trial, the COMPOSE study, for addressing this very patient population, grade 3 well-differentiated NETs. If you don't have access to trial, then we can do off-label PRRT, but PRRT is a good option for somatostatin receptor positive high-grade well-differentiated NET. Other options would include cabozantinib, sunzutant, even everolimus. But again, my optimism of trying these in a very aggressive cancer becomes dwindled. So I have to really study how your cancer is behaving, how aggressive or less aggressive it is. Should I beg, borrow, steal from low-grade NETs or high-grade? So we have to tailor it to your needs, but there are options.
And then if I could add, since we don't have the liver-directed therapy guy, the driver of mortality in metastatic neuroendocrine tumor is mostly that we will lose control of the liver. And then if it goes beyond a certain thing, 40%, 50%, 60%, whatever total tumor volume in the liver, then the benefits or the proven benefits of the techniques that we use goes down. So it's all about sort of focusing on the life-limiting disease. So I think that this is where when you have a balance of powers at the tumor board is that if you're talking about CAPTEM not giving you the expected results, of which the fact is that chemotherapy, I think you quoted 40%, and so you're in the 60% that just strategy just doesn't work. It doesn't necessarily mean there could be a variety of reasons why it's not working in that situation. But I would usually come back and say that liver-directed therapies, he didn't quote it, but liver-directed therapies come within 80% objective response rate, meaning you hit the target appropriately with your embolization, 80% likelihood of an appreciable objective response. That drops to around 50% at 6 months. That's a durable response rate. But the 50% at 6 months can last actually a pretty long time. So if you're looking at the complexity of perhaps you just have too much disease for the systemic options that you are, or the systemic strategy that you are taking, the liver-directed therapies don't care as much about grade, but I want to be clear because I don't want to give people false expectations. The durability of liver-directed therapies in high-grade tumors is not going to be as good as low-grade because it's often got other mechanisms. So you may not have that 50% durable response rate at 6 months. But if the goal is to try to cytoreduce without taking a higher-grade tumor to the OR where there's not any proven benefit, you would try to diminish, you try to get an objective response where you can, and then potentially do whether or not it be off-label use or try another systemic agent to deal with the residual disease burden. And so that's where it's really, really patient-specific, because I agree with him. The G3 well-diff category is the one where I wouldn't have said there are no good treatment options. It's just we don't know what to do with that, because sometimes they'll act more like these good actors, and sometimes they'll look more like the bad actors, but we don't want to,
Correct.
beat Debbie down.
These are very, very challenging cases. We get even more sophisticated. We try to understand their genetic makeup, and sometimes we get clues from there. For example, in my clinic, we do the next generation sequencing of these tumors, and if I start seeing bad biomarkers like mutations in TP53 or loss of RB1, those kind of tell me and pushes me more towards systemic therapy, chemotherapy, and I'm not very much optimistic about local regional therapy, surgery, or for that matter, lower grade NET systemic therapies. On the contrary, if I start seeing mutations which are often seen in grade 2 NETs like DAX, ATRX, PTEN, and other things, then I feel a lot more comfortable about avoiding the IV chemo and maybe start thinking about TKIs and other systemic therapies, and including local regional therapy in the right patients. But grade 3 well-defined NETs is really, really critical to understand the biology of disease and tailor the treatment based on the biology. That means how aggressive or less aggressive the cancer is.
Okay, great answer. Maybe this may be a question for Dr. Esposito. When would you recommend external beam radiation therapy?
Yes, so I am not a radiation oncologist.
Okay.
I would say, of course, this situation when any compression is fine, any force palliative treatment.
Yeah.
So there are situations when you want to do radiation treatment for acute problems like a cord compression or any palliative treatment of pain. These are, of course, some of the indications for radiation treatment. And then, other than that, I don't know, large lesions, again, in trying to reduce the tumor burden for systemic treatments, external radiation could be a consideration, but I don't know, this is not something that we would consider very early at all in the.
Yeah, I completely agree. I think external beam radiation's very limited role as a cancer therapy. It is a great tool for palliation, especially in bone mets. So if you have a patient complaining a lot of pain in one particular area, bring it out to your doctor's notice, because it could be a tumor in the bone, and it responds beautifully to very limited low dose, like your radiation, 1 fraction to 3 fractions, and could be a significant improvement in the quality of life. Outside that, external beam radiation as a means to control tumor, limited, because even let's suppose if it's in a liver mat, I'd rather have Dr. Maluccio take it out, or IR guys ablate it, or embolize it, than do radiation, because there'll be a lot of collateral damage. There'll be a lot of normal liver parenchyma exposed to excessive radiation. So usually for typical NETs, we don't do external beam radiation. One exception is lung. So there are cases for early stage lung nodes, which are not good surgical candidate, because surgery is first, second, third choice for lung NETs if it's resectable. But there are cases where you can't get surgery, COPD or some other medical conditions, or the tumor is in a location you cannot resect it, then I do send them to radiation, and they do focused radiation called SBRT, and that really helps control the tumor for a long time. It might not completely eradicate it, but they kind of stagnates, stops the growth for a significant amount of time. So there's some role in select cases.
Okay, great. So this question, pancreas neuroendocrine tumor, well-differentiated pancreas neuroendocrine tumor, grade 2 with a Ki-67 of 4%. When would you recommend the combination of streptozotocin 5-FU and doxorubicin if Captain is available?
I would never recommend. So I think the use of, if it's limited disease in the pancreas, I am not keen. I can understand a functional tumor to try to decrease the consequences of the function, but that's still a low-grade, well-differentiated pancreatic neuroendocrine tumor. If it is limited to the pancreas, that may not fall into the category where we talk about watchful, waiting and non-operative management. So when we're talking about the risk-benefit ratio, is if you can remove all measurable disease, and the disease is limited to the pancreas, we would choose surgical resection even if you have to do anything other than that central pancreatectomy. So even if you'd have to do a major resection. So there would be other reasons, I think, that you would have to consider systemic agents in that context, but there's nothing about a Ki-67 of 4% if it's limited to the pancreas.
So the chemos mentioned here, streptozotocin and edromycin, 5-FU,
and
doxorubicin. So believe it or not, these are actually approved treatments for low-grade neuroendocrine tumor. Fortunately, we live in an era that we don't have to do it because we have better treatment options. But having said that, there was a time where we used this, and old data, I personally had never had to use it in my career, but these are approved or recommended treatments. So this is not wrong to say if somebody did get it. I don't know in which era they were treating. CAPTEM is a relatively newer modality. The first paper using CAPTEM in neuroendocrine tumor actually came from New York side, Dr. Fine, I think, and it was a small 18-patient single-center study and showed good result. And this is, late 2008 or 2011 or somewhere at that time, right? So CAPTEM, and then we did more prospective randomized studies, and Dr. Coons just presented that data a couple of years back. So CAPTEM is more established in NETs now. So we have to really, also understand maybe the patient got treated at a time where CAPTEM wasn't really accepted standard, right? And these things evolve for the better.
Right. Great. Thank you. Question for Dr. Esposito. How often should dotted scans be done? Dotted scan, how often?
Right, so that depends on the setting, right? So if it is the first time the patient is being at diagnosis, or if we're planning for treatment with PRRT, or if we're following up the patient. So I would say that at initial diagnosis, to stage the disease, I think I would, in general, tend to want to do the PET, dotted PET, because again, even for surgical planning, helps figure out if the tumor is local or not. So we have a lower threshold for doing the PET at the initial staging. And then if the patient tumor is progressing, if we have to prove that the tumor is progressing, depends on CT and MRI usually done first. They're less expensive than a PET CT. There's less radiation involved to it. So if we suspecting that the tumor is progressing, and so the oncologist or whoever's taking care of the patient thinks that there needs to be a change in treatment, then usually again CT and MRI is done. If CT or MRI will give the answer, so the tumor is progressing, then you may or may not need a PET. Right? If you already have the clinical answer and the clinician, the oncologist, or whoever's taking the patient knows now at this point, has all the information and needs to change the treatment, then we don't need a PET CT. However, if we're now planning to do PRRT, yes, we need a PET CT, if not done before or recently, to prove that we have the target expression. During the treatment with the Lutathera, I don't typically necessarily repeat the PET during the treatment. Again, I would follow up the patient. I would do CT or MRI if needed, if the patient has new complaints or suspect there's tumor progression. And I would do the PET if there is, again, a clinical suspicion of tumor progression or something happened to the patient and the CT or MRI does not give me the answer. At the end of PRRT, I would repeat, or at the end of any treatment, I would repeat the first CT or MRI to assess the disease. If I don't have an answer from a CT or MRI, or there's equivocal, I would do the PET later on. Usually I do a PET CT at the end of the treatment that I do the PRRT, at least 6 to 12 months after the end of the PRRT.
Yeah, we have a protocol because every medical policy within an insurance company is going to have different ways that you can or cannot get something. And so the somatostatin receptor PET imaging is not actually a surveillance tool. It is an extensive disease evaluation and is something where you have to make an argument that that information is going to affect the decision you're going to make, aka, PRRT. So I usually will spell it out right at the beginning, and I'll say, okay, I get this somatostatin receptor PET, and then I say there will be a handful of reasons I will get updated somatostatin receptor PET imaging that are according to this medical policy. One is going to be new or worsening symptoms suggestive of the evolution of a neuroendocrine syndrome. 2, new findings on conventional cross-sectional imaging for which neuroendocrine needs to be put in perspective. Or 3, I'm like literally having more findings. New or worsening symptoms, new findings on or changes in blood work that would suggest a serologic progression of disease, for which then you would need that because you're looking for a needle in a haystack. And even then, they can come back and say, hey, that's not quite enough information about it. But that I agree that whenever you're saying, hey, I think, one, someone that's got multi-organ site involvement, including liver, lymph nodes, bone, you will never get all of those with a single scan. And so you always feel like you're just underrepresenting the disease on conventional cross-sectional imaging. So you can make that argument for it, but that it's not like the insurance company is trying to dog us. It's just that it's not actually changing that which we do unless we are actually getting it for a particular reason. So it's really not a surveillance tool. There's a reason to get it, whereas the other things are usually on a schedule of every 6 to 12 months.
Yeah, I really want to highlight that point because a lot of patients feel that DOTA PET is better than other scan. I don't think any scan is better than other. I think each scan has its own role, right? So if we have we want to know the extent of disease in the bone, or we are qualifying patient for PRT, DOTA PET is essential. It's absolutely must. But for monitoring the disease, a triple phase CT or an MRI with liver protocol, that's really good. In fact, in clinical trials, we don't do DOTA PETs for monitoring because it can be inaccurate for monitoring. It doesn't give us exact dimensions like we want to. It tells us the overall burden of disease, but if we have a target lesion and we have to track it down, a cross-sectional image like CT or MRI is far superior. So both have its roles. So you shouldn't really feel, oh, I need to get DOTA PET to get, but there are sometimes there's so much disease in the liver, a cross-section image cannot give us good idea. In that unique scenarios, we do use PET scans if the insurance would allow us.
Sure.
I completely agree with all that's been said, and I forgot to mention the insurance factor as well. There is, I took it out at the last moment from my slides, but there are guidelines, so appropriate use criteria guidelines that we often refer to those. And one of these guidelines is produced by the Society of Nuclear Medicine, and so one could often refer to those guidelines. There was something else I was going to say, and I forgot. Oh yes, so when we follow up and we compare PET to PET, and obviously the SUV value, which quantifies how much activity there is in a lesion, right? That's a question that we're often asked both by referring physician and patients. In DOTA-TATE, with DOTA-TATE PET, changes in activity, high activity is good for us when we plan to treatment, but changes in activity that needs to be taken with, to be careful about what is the meaning about changing activity, because this is just the expression of the receptors is changing, and there are a lot of factors in the biology of the tumor and the patient that can affect that. So we shouldn't use those as a measure of saying, oh, the tumor is getting better or the tumor is getting worse.
Yeah, great. I do want to ask this question, and Dr. Chauhan, he's double boarded in pediatric and adult care. So, Dr. Chauhan, for younger patients, what treatments have the lowest risk for reproduction fertility?
That's a tough one. So fortunately, most of our pediatric NET patients are caught early, and our surgery colleagues helps us out because they cure them with surgery. But in those very few patients where it is already metastatic, that we are, first of all, there's no approved treatment. So we kind of make decisions based on what's available, what we can get, and of course, all the same nuances we use in adult patients. So somatostatin analogs, to my knowledge, is not teratogenic, and I don't think it causes fertility issues. And Dr. Delriveau can also add to this. But radiopharmaceuticals have not been tested in pregnant females. I bet it is teratogenic, right? Just intuitively with the way it works. Chemotherapies, again, we don't even test them in pregnant. There are certain chemotherapies have been tested and are allowed, in certain trimesters of pregnancy and stuff. So we have some safety data for fetus, but not all. It gets very challenging. Regarding fertility, if a patient will need to be treated with a cytotoxic treatment, be it chemo or radiation, it is very important to seek fertility consult early. Almost every dedicated cancer centers have a specialized person who just deals with counseling part of it, and also fertility preservation. That means in the right patient population, right? But these are not easy answers. And in pediatric NETs, I do want to give a shout out. We finally have a clinical trial evaluating PRRT in metastatic pediatric NET patients called NETTER-P, and these are all the considerations there as well, But there's, outside somatostatin analog, I doubt any drug is completely safe from that standpoint. Right, Dr.
No,
Deborah?
I completely agree with you, and I think you say very nicely that in younger patients in reproductive years, it's important to see a fertility preservation physicians to discuss the options of what can be done. Absolutely. So I'm going to ask a question. So on the Gallium-68 scan, pancreas neuroendocrine tumors with 3 positive tumors on the Gallium-68 scan, based on that information, am I a candidate for PRRT? Dr. Esposito. Dr. Esposito.
Yeah, so this is a new diagnosis.
Pancreas neuroendocrine tumors, 3 lesions in the liver, seen on 68 gallium dotted scan. Would you recommend PRRT there?
Yeah, so PRRT is not indicated for as first-line treatment.
Mm-hmm.
So I think that's the main thing. So other treatments first would have to come, with a surgery or Lenritada, Octreotide, but definitely not at this point. Yeah.
Mm-hmm.
I agree. I mean, PRRT is a good second, third line in the right patient. If there is, again, low volume, low bulk disease, you might even want to consider observation versus starting somatostatin analogs, and trending the disease biology and loop in our surgery colleagues. Maybe this is all resectable at some point in time once we understand the biology of the disease. So definitely don't be in a hurry to jump on PRRT. These are not curative treatments, and we want to use this treatment when there is enough bulk or disease, because it's very limited. Even with the repeat PRRT, it's not that we can do it unlimited number of times. Your body can only take enough radiation, right? So you want to use it in future, maybe 5 years from now, or 3 years from now, or 10 years from now, when you truly need it, right? So don't be in a hurry if you just have 3 spots and you have not even tried anything else.
Yeah, I agree. So the thing about multifocal pancreatic neuroendocrine tumors, one, we send, I don't know what the other people do, we send you for genetic testing. So multifocality in PNET is not necessarily associated with familial disorder, but more likely to be. 2, we do not rush into surgery. It is unlikely, but not unheard of, to do a total pancreatectomy in the setting of multifocal PNET. But if it's otherwise low grade and got an indolent biologic behavior, that's going to be one of those things. It's a trade-off of one problem for another problem, which is the diabetes related to that operation. We have definitely had to do it, unfortunately, in people with gastronoma, because if your gastrin levels are in the several tens of thousands, that you end up having complications of the disease, and so you are trapped. You won't commit to a total pancreatectomy right off the bat, but you will try to eliminate at least the measurable disease. And I would have said that the answer, if someone said, "Hey, I just got this diagnosis yesterday, this is what they're telling me I've got to have. This is what the scan is telling me," I would be putting them on somatostatin receptor inhibitor therapy and holding the course.
Okay, great. I was given permission to ask a few more questions. I know that we're, if you're all okay.
I'm not going anywhere. I can't pull my flights to go sooner, so I don't know about these guys.
Okay. Okay. Just this is another question. My tumors continue to grow with lanreotide shots. This means that my tumors do not longer have the receptors, and what are the chances that my tumors will respond to PRRT?
I think that's a great question. I don't think response to somatostatin analog really correlates with presence of receptors, although theoretically we do know that analogs work on the receptors, etc. But the anti-tumor response, we don't know whether it has anything to do with the receptors or the receptor down regulations, etc. The tumors respond to somatostatin analogs for variable length of times. In clinical trials, we have seen anywhere from a year to, we know in real life, many patients here for several years, sometimes even a couple of decades, right? At some point of time, something would change in their genetic makeup and something would flip. There are various tumor pathways. One of the pathways is mTOR pathways, mammalian target of rapamycin. This is a pathway related to tumor growth, right? So something flips in the tumor as they're trying to grow, because they're also trying to fight, right? We are giving them medicine to kind of slow them down, but they're constantly trying to survive that onslaught. And eventually they figure it out, and they figure a way out, and that pathway takes off. And that's why we need newer treatment. So if somebody is progressed on somatostatin analog, and it's just not a functional neuroendocrine tumor, that means the analog was done primarily only for tumor control, not for flushing or carcinoma or anything. In that case, we will stop the shots and start on the second line of therapy. Now, that could be PRRT if they still have receptors. So that's where presence of receptor helps us in picking the next line of therapy. Or that could be everolimus, which is an mTOR inhibitor. Or other therapies, including, based on where the disease is, how much disease, including surgery or other things. But I don't think lack of response to somatostatin analog eventually is nothing to do with the receptor expression per se. We know very well the majority of patients at progression still have somatostatin receptors. They don't really become DOTA negative or receptor negative at progression.
Yeah, and from a simple surgeon standpoint, so there could be a variety of reasons, correct me if I'm wrong. So one, it's a drug, and therefore there is not uniform distribution. So you will not necessarily get appropriate levels of the drug in whatever location it is in. I've also felt that if you have bulky disease burden, I feel like it may be unrealistic to think that somatostatin receptor inhibitor therapy alone would be able to control that extent of disease, whereby if we were able to reduce it in some way, shape, or form with other therapies, would then that be a better option? And then two, the backbone of the drug is different than the backbone that we use for the PRRT. So if you're looking at where we think that the PRRT is going to go, what I tell people, using my little car analogy, is that PET scan that we do, whether or not it be the copper or the gallium-68 PET scan, is using a backbone that is identical. So you take the pizza delivery light off, you're putting lutetium-177 on, and the European studies showed that if you sent the patient from the lutetium-177 to the scanner, and then you looked at the gallium-68 PET scan done beforehand, they were almost identical. So it's almost like that at least your treatment's going to go, and you can even, if you were really good at dosimetry, actually even start to measure actually where it goes. So I agree. I think we're saying the same thing. Mm-hmm. I agree that I would not cut bait on a receptor targeting treatment just because lanreotide is not giving you the expected result.
No, right. Just along the line of what we were saying, it depends, of course, where the lesion is. If it's I understood it's just one lesion, right? From what I understood from question, if it's just one lesion, of course, if it's in liver, then you think about other liver-directed treatments. If it's reasonable, if it's so I had one patient had one lesion in the pancreas which was inoperable. We treated him with the PRRT for times, and we were able to shrink the lesion, by greater than 90%. And so very, very effective. So it all depends. If it's just one lesion, it's inoperable, or there is not in liver where you can do liver-directed treatment. PRRT, if it's PET positive, it could be more effective than if we have a lot of, many lesions and large tumor burden.
And then if I could ask, actually, Aman, there are sometimes, so if someone's on sandostatin, so that's going to be LAR versus lanreotide, I think some of us have a concern that perhaps that therapy may be not as effective because it's not distributing from the intramuscular space. So people that are on that drug is, if in the south where you may have someone with a relatively large backside and that needs to get into the muscle in order to biodistribute properly, that may be a failure of actually the drug delivery system that we have, and we would then end up just shifting those people over to lanreotide before we cut bait on somatostatin receptor inhibitors. And then, even though I'm not sure that the pharmacokinetics necessarily pan out, because head-to-head they were used interchangeably. Both did progression-free survival benefit, both did control of symptoms, yet there's something more reliable when you think about biodistribution from the subcutaneous space, which is why we give Lovenox and insulin and things like that into that subcutaneous space. So I feel like there could be a lot of reasons that we don't understand. I think we're probably I think it's only Iowa and New Orleans that ever get those drug levels, but that we have seen patients that are on the same dose, drug for drug, and aren't even that much of a difference of BMI, not be able to get very high drug levels, and I think it could just be either a biodistribution of a metabolic problem.
Yeah, I mean, so it sort of depends on at the progression, what's the nature of progression? Again, comes back to very individual question. So if patient otherwise had a lot of disease and every side, the somatostatin analog was working fine except for this one spot, starts growing, you don't want to change the whole regimen because it's working fine for all other issues, and we can easily embolize that. So it would be a very good way to treat that. But usual progression, what happens is the cancer clones usually work in unison, usually. So if there is progression, there is more than just one lesion which is progressing, okay? And if that is the case, then sometimes the right approach is to change the systemic therapy altogether, right? If there's a very minimal progression, just a couple of millimeters, maybe you don't want to change the class of drug. So if somebody for some reason was on 20 milligrams of sandostatin, I would consider that there is room to do actually 30 or higher doses, right? Lanreotide, we don't have that flexibility. It kind of comes in 120. We often don't use 90, which is more reserved for the endocrine disease patients. But for some reason, if there was somebody was on lower dose, 90, and now there's mild progression, maybe you want to put them on 120. But the usual course is most patients who are progressing, they even have new lesions, or somebody has significant 1 centimeter growth or multiple new growths. You really want to kind of switch the therapy and move from frontline therapy to second line therapies, which we have multiple other options. And why that switch happens, needs to be figured out. The mechanism for resistance, there have been a lot of postulated mechanisms of resistance, receptor downregulation, hypoxia-induced factors, and certain pathway activations like VEGF and mTORs and things like that, which we are trying to understand and target. One of the drugs that I talked about, cabozantinib, it targets some of those pathways, and that's how we control the tumor. So it's a complex situation. That's why cancer is a complex disease. If we knew why the cancer progresses, we could have easily fixed it. It's not one thing, it's multiple things, all happening same time.
Okay, that's great. So I think this question is a good question, and maybe I'll start with Dr. Esposito, and then after that, Dr. Chauhan, you can answer. There is a study in the Netherlands of trying to add receptors to tumors that do not have the receptors. So what are your thoughts about that, and how successful do you think it could be and be available in the United States?
Yes, I don't know, of course, yet. I don't know if we have enough data to definitely say that this is helpful or not. And I don't know actually about the United States, to tell the truth. But this is not the first time that we will be doing something. For example, for thyroid cancer, it's being done the same. It's still in clinical trials, but a little more advanced. So thyroid cancer takes up iodine, we give radioactive iodine, it doesn't take it anymore. There are drugs that can reinitiate the expression of the iodine transporter. So that's it. So the concept is not new and has worked in the past. It seems to be working. So I think potentially is a good,
I think it's a good strategy for scientists to think in terms of how we can make receptor negative patients into receptor positive, but it's nowhere close to successful human sort of intervention. I know that there are certain labs in the US testing these hypotheses with medications, which causes upregulation of somatostatin receptors. But these are, to my knowledge, not even animal models. We are talking about petri dishes and cultures. So very, very early stage. But this is one of the ways we kind of think we always challenge ourselves that can that be done? Because imagine if it can be done, we can essentially improve the effectiveness of PRRT because we improve the receptor. That's the motivation why we want to develop a drug which can increase the somatostatin receptors. But it's nowhere close to prime time.
Okay, that's very good. Next question, Dr. Maluccio. What is HIFU and what is indicated?
So HIFU is a high-intensity ultrasound treatment, and it is FDA approved for the use in certain types of the body. I think it's more, not necessarily when HIFU is indicated, because I think HIFU is going to be replaced very quickly by something that's non-thermal. So if you were to take like those little Theragun things that the athlete trainers do, and they are putting it on your muscle, and you're like, ooh, that gets really hot. HIFU is generating enough ultrasound waves in order for thermal injury to then ultimately then destroy the tumor. But it's the thermal injury associated with it that is ultimately associated with the side effects, and therefore not making it as generalizable to other parts of the body like the pancreas. So I think the thing that we're really actually looking forward to at least seeing whether or not it makes it, once again, we're in clinical trials, is using something called histotripsy. Histotripsy is also using ultrasound type waves, but it is non-thermal. And so it's trying to target very tight areas using a very almost relatively pinpoint accuracy. It is non-surgical and it is non-thermal. So it's taking away a lot of the complexities of some of the ablative techniques that we have used to date. And it's probably going to be a superior to HIFU. So HIFU is predominantly used in kidney, to be honest with you. And so the kidney and the liver can take a lot. And so even if you do get some stray artifact or whatever, but in neuroendocrine, it's not actually all about that. It's about complexities of the retroperitoneum. What do we do when it's in the pelvis? What do we do when it's the base of the mesentery, where you have a lot of problems with local tumor growth, and the surgical operation, anything short of a transplant, is going to be too busy. And so I foresee, maybe not HIFU, because HIFU never generalized outside of a very tight niche. Do I think that histotripsy has the ability to do that without, I don't get paid by the histotripsy people, so I'm not saying anything for money. So histotripsy is probably got more breadth to it, or more bite to it as a use, and I think that's probably going to come onto market maybe by the end of the year.
So I was asked just to know, excellent questions, by the way, but I only have time for one more question. If you have any other questions, the speakers and the experts are going to be with you for a little bit. And this is
you all can come to Miami for more questions.
Yes. So I learned this morning that octreotide can cause problems with the gallbladder. What are those problems, and how long after it can happen when you start octreotide or lanreotide?
I can start, but I think Dr. Maluccio would be a great person to chime in for that. So somatostatin analog slows down the peristalsis, and other thing that it does is kind of slows down the contraction of the gallbladder. So all that bile and the sludge, eventually they'll kind of accumulate and become stones, and then gallstone happens. It's not a matter of if, it's a matter of when. So that means that patients would almost always get the stones. But it doesn't happen right away either. So I've seen different people, different things, different pace. So my usually, take on this is when we have opportunity to get some sort of surge in patients, we also use that opportunity to take away the gallbladder at that point in time. And that kind of, we keep it in the radar. We also are watching patients, right, because we are doing serial scans. So it's not that we don't know what's happening with the gallbladder, if it's getting distended, if it's getting inflamed, if there's a lot of stones. Clearly, if patient's getting symptomatic, they need to get it out. But we have opportunities. But maybe Dr. Maluccio can tell us about the timing. When do you do the surgery, or when do people naturally develop significant gallstones, if let alone?
Yeah, I think sort of similar. So octreotide is cholestasis. And so it doesn't necessarily mean that the gallbladder becomes diseased. It means that everything just sort of slows down the flow. If we are operating on someone with a mid-gut primary, even early stage, we will routinely discuss taking out the gallbladder, because mid-gut neuroendocrine tumors are more likely than like non-functional pancreatic neuroendocrines to need somatostatin receptor inhibitor therapy over the course of their remaining lifetime. And then you just eliminate at the beginning. So we have a really low threshold for removing the gallbladder, even if that problem with the gallbladder is not going to happen for years to come. We routinely don't even really give someone the option if they have node-positive neuroendocrine and therefore are at increased risk for needing somatostatin receptor inhibitor therapy over the course of their lifetime. We remove the gallbladder. When it becomes an issue is when someone has systemic disease for which we are starting them on the drug before considering surgery of any kind, because to delay it and not put them on a drug, not understand the disease process, and then go in and take a gallbladder, even if it's a low-risk operation and have a problem, you'd be like, what the hell did we do that for if the person didn't actually have a problem at that time? But I will tell you, we have had people have significant gallbladder issues. I had a gallbladder rupture, and why it happened in that person versus another person, and all we were doing was kicking ourselves and like, why did we not take out the gallbladder? But those are like the anecdotal, those are like the handful of people, and each of us up here treat hundreds and hundreds of people and not have that happen. So yes, we will routinely take out the gallbladder, especially in the mid-guts, and definitely people that need to be on somatostatin receptor inhibitors long term.
Glad surgeon and oncologist agrees for once.
Okay, well, this ends our session, our Q&A session, and now we have Marianne with the closing remarks. Thank you.